We'll give it a minute or two for our attendees to filter in so they're not coming in too late. We want to make sure that they hear the beginning of the conversation. Okay, so we'll get started now for the sake of time. I know more people are likely going to filter in, so I wanted to thank everybody for joining our discussion today. It's been a while since we had one of our more formal Roswell Park Center for Indigenous Cancer Research Talking Circle webinar discussions, but this is okay. And so this is an exciting discussion today. It's been several months in the making, and we'll set the stage by reiterating the title of today's talk. It's Improving the Care of Indigenous People with Cancer, Staffing and Teamwork Matters. Now, improving health outcomes for Indigenous people by providing person-centered, culturally safe care is a vital challenge for the health sector. In Australia, particularly in regional and remote regions, Indigenous Australians experience poor health across a range of outcomes. While many health services are committed to providing high-quality care, they struggle with providing accessible, culturally safe care to Indigenous Australians and with recruiting and retaining Indigenous staff. Through a multi-stage national study, we identified 2 Australian health services as particularly high-performing and innovative in their provision of cancer services for Indigenous cancer patients and their families. We will discuss how these 2 health services support their Indigenous staff through workforce policies and strategies, and how Indigenous people affected by cancer experience care at these services. This is exciting because it parallels the work that we strive to do at the Roswell Park Center for Indigenous Cancer Research. And I think for us as a team, we will learn a lot today as well. So it's double exciting in that sense that not only is our audience going to see the parallels of the work that's being done across the entire country in the Indigenous health and cancer space, but also as a team, I think there's a lot for us to learn and from these other high-performing organizations who have been successful in providing that additional supportive care for Indigenous cancer patients. So I also want to move on to introducing our speakers today. So we have a 4-person panelist, all from Western Australia. And before I get started, I wanted to make a sort of a special acknowledgement to my best friend who's on the call, who is actually from Perth. He's in close proximity to our speakers today, and I thought that was really interesting. So Danny, if you're on the call, welcome. It's good to have you. And so our lead presenter today is Emma Taylor. She's a research officer with the Western Australian Centre for Rural Health. And her co-leads today are Sandra Thompson, Professor of Rural Health at the University of Western Australia and Director of the WARCH, which is the Western Australian Centre for Rural Health. Lenny Papertalk, Research Assistant and Community Engagement Officer, Western Australian Centre for Rural Health, the WARCH. And Leanne Pilkington, Senior Program Officer with Aboriginal Health Strategy at South Metropolitan Health Service and Chair of the Cancer Council, Western Australia Aboriginal Advisory Group. So we have quite an esteemed group here. And Emma's going to lead the discussion today with Lenny, Leanne, and Sandra helping to support any Q&A, any specific questions that we have at the end. And so we'll save approximately 10 to 15 minutes at the end for questions. If you have any questions in the meantime, as they come up during the discussion, please put those in the chat box. And I also wanted to acknowledge our special co-host today, Dr. Ken Bataille. Dr. Bataille is a new professor at Roswell Park and a colleague of ours. He's an assistant professor in the Department of Cancer Prevention and Control at Roswell Park Comprehensive Cancer Center. He is a cancer health disparity and health equity researcher trained in anthropology. He has worked with various minority groups in the United States, including indigenous communities in Arizona, to address cancer disparities. And we want to, at CICR, we want to give Dr. Bataille special thanks for linking us up with our group here from Australia. He saw some similarities and parallels in the work that we're doing and thought it would lend itself to a really interesting and hopefully fruitful discussion. So I will hand it over to Dr. Bataille.
Thank you. So first of all, I would like to thank Dr. Taylor, Dr. Thompson, and their colleague joining this webinar. And I know this is late in the night in Australia. I got to know their work when they submitted a paper to a cancer health disparity and public health special issue for journal that I'm guest editing with my colleague. I really enjoyed reading their submitted work, and I read some previous work as well. And then I thought it would be nice to invite them for a webinar, so we can learn more about their great work they're doing for Indigenous people in Australia. So I'm very excited to see what presentation this morning. So Emma, please go ahead and share your, and please welcome Emma and colleague.
Thank you very much, Ken. And before I begin, I would just like to begin by acknowledging the Yamatji people, who are the traditional custodians of the land where I live and work. I want to pay my respects to their elders, past, present, and emerging. And I extend that respect to all First Nations peoples present here today. As said, my name is Emma Taylor, and I'm a research officer with the Western Australian Centre for Rural Health at the University of Western Australia. I'm actually from Perth, which is the capital city of Western Australia, but about 8 years ago, my family and I moved to the small, windy city of Geraldton, which is about 4 hours drive north of Perth. And today I'd like to share some of our research. So I'm just going to share my slides. There we go. Just checking, can everyone see the slides?
Yes.
Fantastic. So our research was actually part of a national project that aimed to find some of the best, most supportive, culturally safe cancer services for Aboriginal and Torres Strait Islander people and to learn from them. We identified a number of services and they agreed to participate in case studies. Today, I'd like to tell you about what we learned from 2 of those services specifically, about how they look after their Aboriginal patients and their Aboriginal staff. And then hopefully at the end of the session, we can have some good discussion as well, because as Ken has said, I think there's a lot of similarities and commonalities between our countries in terms of the issues and the challenges that we're facing in delivering supportive Indigenous cancer care. And I think there's a lot that we can learn from you as well about the ways that you're supporting your Indigenous cancer patients and their families. But first, I'd just like to acknowledge that we could not have done this project without a lot of support. The project was actually part of a big national Centre for Research Excellence with a rather lengthy acronym, Discover TT. This stands for Discovering Indigenous Strategies to Improve Cancer Outcomes via Engagement, Research Translation and Training, which is a bit of a mouthful. And that was led by Professor Gail Garvey, who was a Kamilaroi woman, and she was the chief investigator on that project. And I also want to acknowledge my Aboriginal colleagues over East, without whom these case studies couldn't have happened. Now, I thought it might be helpful to set the scene for our research. I'm not sure how much you all know about Australia, but you might not realise that Australia is really large. In fact, it's about the same size as continental USA. To put it in perspective, and here I've got the maps superimposed. I've got a map of Australia superimposed on a map of the United States. The map of Australia is actually a little bit smaller. It should actually even be a bit bigger. So traveling from Sydney, I'm sure most people have heard of Sydney, to Perth, which is where I'm originally from on the West Coast. That's the East Coast to the West Coast. It's about the same distance as traveling from New York to Los Angeles. However, although we've got similar size, our population is significantly less, and I've got the numbers there on the slide. Basically, the population of Australia is similar to that to the state of Florida. Sandy, Lenny, Leanne and myself are all from the state of Western Australia. If you're not sure where that is on the map, it's on the left-hand side of Australia. It's sort of that left-hand third, and then you've got the white line dividing it. You've got the cities of Perth and Geraldton in Western Australia. Western Australia is very large. It's bigger than Alaska and Texas combined, and has a population of 2.6 million. The capital city, Perth, has a population of about 2.1 million. So you can see where all the people in Western Australia live. In fact, that's pretty standard across Australia, to be honest. The majority of the population live in large urban centres on the coast. There is considerably less population once you get inland away from the coast. Geraldton, where Sandy, Lenny and myself live and work, has a population of approximately 40,000. And like I said before, we're about 4 hours drive north of Perth. You may not know that there are actually 3 official flags in Australia, and I've got them down the bottom on the left there. We've got the Australian national flag, that's the blue one with the stars that you may have seen before. We've also got the Australian Aboriginal flag there in the middle, and the Torres Strait Islander flag on the right. That's the blue with the whites in the middle. If you're wondering about Torres Strait or the Torres Strait Islands, which I will mention a little bit more in my talk, the Torres Strait Islands are a group of about 270 small islands up in the top right-hand corner of Australia. So above the state of Queensland, up the very top, I've got a red dot where it says Torres Strait Islands. So they're sort of between Australia and the island of New Guinea. And that's where the Torres Strait Islander people come from. The islands have a population of approximately 4,500. So very remote. Now, I thought it would also be really helpful to set some background about Aboriginal and Torres Strait Islander people. So Aboriginal and Torres Strait Islander Australia is actually made up of many different and distinct groups, each with their own culture, customs, language and laws. They're the world's oldest surviving culture. And I've got a map here on this slide which attempts to represent some of the language, social and nation groups of Aboriginal Australia. So huge diversity of cultures. Aboriginal and Torres Strait Islander people make up 3.8% of the population of Australia, so about 984,000 people. 91% of those identify as Aboriginal, 5% identify as Torres Strait Islander, and 4% identify as both Aboriginal and Torres Strait Islander. And that's why I was just mentioning the Torres Strait Islander flag and where the Torres Strait Islands are. Most of our Aboriginal and Torres Strait Islander population live in major cities or regional areas. So about 80% live in either a major city or a major regional centre. But once you get out to remote and very remote areas, they make up a much higher proportion of the population because, as I've already flagged, most of the Australian population lives on the coast. Once you get remote, there's much smaller populations, and yeah, Aboriginal people make up a much higher proportion. The Aboriginal and Torres Strait Islander population is much younger than the non-Indigenous population due to high levels of births and deaths. The median age is 24 compared to 38 for non-Indigenous. Aboriginal people, unfortunately, have a much higher burden of disease, about 2.3 times that of non-Indigenous Australians. And on average, they live 10 years less. And that appalling statistic was actually the impetus for the Australian government in 2008 to launch the Closing the Gap strategy, which is a big strategy here in Australia, which aims to close the gap in life expectancy by reducing disparities on key health, education, and economic opportunity targets. So that's been the Closing the Gap strategy has been in play in Australia here for 14 years now, unfortunately with not as much success as we would have liked, but certainly raising awareness. Cancer in Aboriginal and Torres Strait Islander people is a huge issue. Over the last decade, it's been great. We've seen improvements in health outcomes for Aboriginal and Torres Strait Islander people across a range of chronic diseases, which is fantastic. But unfortunately, we haven't seen those improvements in cancer. In fact, over the past few years, cancer has actually overtaken cardiovascular disease to become the leading cause of death for Indigenous Australians. So Indigenous Australians are 14% more likely to be diagnosed with cancer, and they're 20% less likely to survive at least 5 years after diagnosis compared with non-Indigenous Australians. And once you get to the regional and remote areas, survival, those statistics are even worse. And what is even more concerning is that the gap is actually widening. In the last decade, the death rate due to cancer has increased by 12% for Indigenous Australians, while at the same time it has declined by 10% for non-Indigenous Australians. So, yeah, a lot of work needs to be done here, which should have formed some of the background of our research and why we're working in this space. There's already been quite a bit of research done over the last 15 to 20 years looking into these issues. So there are some things that we do know. We know that there are many factors contributing to the poorer cancer outcomes for Aboriginal people. This includes lower participation in screening programs, later stage diagnosis, the presence of comorbidities, lower uptake and completion of cancer treatment, and entrenched racism in the health system. We know that Aboriginal people face many challenges engaging with the health system, including fear or mistrust of mainstream health services, poor communication and lack of respect shown by health service providers, experiences of racism, and also just logistical difficulties accessing treatment services, particularly once you start to get out to regional and remote areas. Therefore, we know that cancer service providers are vital to improve outcomes for Indigenous Australians by improving the accessibility of their services and the cultural safety of their care. We know that we need more Aboriginal people in the health workforce, and Aboriginal Australians have long requested to have Aboriginal health professionals involved in their healthcare because this increases the likelihood of culturally safe care. However, many health services, unfortunately, are struggling to recruit and retain Aboriginal staff. We also learned through our research that many mainstream health services want to do better in this space, but they're not sure how. They're not sure who's doing well that they can learn from. So this is really where our research came in. So the questions we were trying to answer, first of all, we wanted to know where do Aboriginal and Torres Strait Islander people receive cancer treatments, because there wasn't really any data on this. We wanted to know what cancer services were doing to meet the needs of their Indigenous patients and their families. And we wanted to try and identify some best practice cancer services that were particularly focused on providing culturally safe care, evaluate them and learn from them, and then share those learnings with other cancer services. So this slide just shows the lengthy process that we went through. It was a very lengthy process. I joined the team in 2015, so I haven't been quite there from the beginning, but it's been going on for quite a while. So we've been going through a very lengthy process to identify the two services I'll be telling you about today. Originally, we started by surveying all hospitals and cancer centres providing cancer treatment in Australia. From the results of the survey, we then identified services that seemed to be trying to look after their Aboriginal cancer patients, had sort of some policies or programs in place to look after those patients. So we had telephone interviews with 14 services to sort of learn more about the programs that they had in place. Following on from the telephone interviews, we identified 5 cancer services that seemed to be particularly high performing and innovative as well in their provision of cancer services. And they were invited to participate in case studies. And then from the case studies, the 2 services stood out as particularly high performing with regards to the support they offered their Aboriginal patients and staff. So we are definitely not saying that these 2 services are the best in Australia, nor are they the only high performing services. Certainly we are aware of others. I just do want to flag that they were identified through a multi-stage national study. And I will just mention as well that unfortunately, one of the services that we identified through the interviews and we asked to participate in the case study actually underwent some changes in the organisation during that time. And by the time we conducted the case study, they were no longer considered by the research team to be high performing with regards to the care they provided to their Aboriginal patients. So therefore is not included. So I think that does highlight the difficulty that organisations can experience with sustaining high performance in this area and how fragile high performance can be when it relies on 1 or 2 champions. So to tell you about the services that we identified, the interesting thing is that they represent some of the diversity that exists between health services here in Australia. Both of the cancer services were located within public tertiary teaching hospitals, so both in big public hospitals. But one service was actually privately run in a public inner city hospital in a state where Indigenous Australians account for about 0.8% of the population, so proportionally quite a small proportion of the population. The other service, the regional service, is located in a regional centre, 620 miles from the next tertiary hospital. So although it's a regional centre, it is actually quite remote from other services, and that's run by the State Health Service. In that area, Indigenous Australians account for approximately 8% of the region's population. And that wasn't a deliberate choice on our part. We didn't pick these services because they were different. They were just the 2 that stood out to us as being particularly high performing. But it is interesting for me that they weren't using any of these things as excuses. They weren't using their location, or their management structure, their patient cohort, or lack of funding or availability of Aboriginal staff. They didn't use any of that as an excuse for inaction, like a lot of the other services that I spoke to over the course of this study. Instead, both cancer services and actually both hospitals as well had made a very long-term commitment to improving Indigenous health. And they'd worked steadily over a number of years to improve healthcare delivery. And I think that's is what made them able to provide such a good service. This wasn't just a short-term thing, and this was a whole of service initiative. So in conducting the case studies, this ended up being a qualitative research. So most of our data was gathered via interviews. And we interviewed 24 hospital staff, both Indigenous and non-Indigenous, and 8 Aboriginal people affected by cancer. So 5 patients and 3 family members. Half of our participants identified as Aboriginal or Torres Strait Islander, including a third of the staff. The staff that we interviewed fulfilled a range of roles in the organisations, and I've actually got that listed there on the slides. On the slide you can see nurses, oncologists, managers, admin staff. But I just wanted to flag the role of Indigenous Liaison Officer because I will be talking about that a bit more, and I don't know if you have anything quite comparable in the States. So here in Australia, Indigenous Liaison Officers, they're also called Aboriginal Liaison Officers. They are people who identify as Aboriginal Torres Strait Islander. And you actually find Indigenous Liaison Officers employed in a range of organisations, not just hospitals, but also with the police force, with the defence force, in schools, in prisons. Lots of different organisations employ Indigenous liaison officers. But in the health service, you get Indigenous liaison officers. They're not usually a clinical role. They work with health staff to support patients and their families. And in fact, the role does actually vary hugely, which can actually be a problem with the role. It can be very broad, very vague, very hard to define, which can lead to issues such as burnout, as we know from previous research. But the Indigenous liaison officer role can encompass patient advocacy, education, support for patients and family, and often acts as an intermediary between patients and healthcare staff. So just a little bit about that role, because we will be talking about that some more. So it's different to the navigator role that I know you guys have at Roswell Park. So one of the things that we found from these two health services that we didn't actually go in expecting to find, I'll be honest. We went in more focusing on the experience of the Aboriginal cancer patients and their families, but a big finding that came through from the data was the way that both services supported their Aboriginal health workforce. And this was a really fantastic finding for us. It was, but it was also a really interesting finding because a lot of services, unfortunately, in Australia don't necessarily do this very well. They might employ a couple of Aboriginal staff at their health service, and it can be a very big Western, very biomedical service, and those staff can feel very isolated, and sometimes can just get very dumped on, made responsible for anything Aboriginal related, maybe not very well managed or supported. And so then that sort of comes back to the point I made in a previous slide about then health services have difficulties with recruitment and retention when that occurs. But these two services were different, and they looked after their Aboriginal staff through a lot of different ways. And as I've already mentioned, it started from the top. This isn't just specific to the cancer service. This was the whole hospital, the whole tertiary hospital. And it started from the top. It started with the executive leadership, really making a commitment, really walking the talk. They had their commitment to improving Aboriginal health embedded in their vision statements. They had active reconciliation action plans. Those are plans here in Australia which organisations can register with a national board to sort of show their commitment to reconciliation and improving outcomes for Aboriginal people. And the progress on those plans was discussed at every executive meeting. So it was really that high level focus. And they had a lot of policies and employment strategies at these organisations, which were measurable and trackable. And this was something else that we found that was a bit unusual, unfortunately, compared to, say, other organisations where maybe this work was just being done by one or two champions, who then, when they left or got burnt out, then unfortunately the work would cease or would drop away. But in these organisations, it was, like I said, led from the top, but they'd actually put it into policies and procedures to sort of keep it fresh, keep it reporting. They had specific measurable targets for the employment of Aboriginal staff. So not just something airy-fairy like we'd like to increase our Indigenous staff, but we want to increase it to 8%. We want to increase it to population parity for our area, or we want to increase it to this specific number. So very measurable and trackable. And both services also employed comparatively large numbers of Indigenous staff in the service as well, compared to most other services that we looked at and spoke to. Both services had what we called an Indigenous Health Liaison Unit, or Aboriginal Health Liaison Unit, which is a specific department within the hospital led by Indigenous staff that was responsible for ensuring that all the Indigenous staff in the health service, particularly the Indigenous liaison officers, were appropriately managed and supported. And making sure that those Indigenous liaison officer roles were appropriately defined, and that weren't too broad, and that they were really protecting and supporting those staff and making sure workload was allocated appropriately. And the Indigenous liaison officers themselves were a very important role within the organisation. Like I said, the role was clearly defined, and they'd actually both services had put systems in place to ensure that Indigenous liaison officers were involved very early on when any new Aboriginal patient was admitted to the hospital. So it was that automatic involvement, particularly when they were admitted to the cancer centre. Systems were in place to notify the Aboriginal staff so that they could go and make contact with the patients and their families. And they were sort of taking on an informal navigator role, but it wasn't formalised and it wasn't called that. The services also did a lot of work on supporting the staff through professional development. So in other services we looked at, the Indigenous liaison officers were a very broad role, like I said, and there might be one or two for the whole hospital, and they were expected to work across the whole hospital, which, as we all know, can be very, very broad area to support. In these two services, they'd actually found Indigenous liaison officers with an interest in cancer, and they were assigned specifically to the cancer department, to the oncology ward. And they were provided with opportunities to upskill in that area and attend professional development and conferences and really sort of strengthen their skills and their knowledge. The physical environment as well of both of these services was interesting. There was a lot of sort of just visual displays of support for the Aboriginal culture. So there was Aboriginal flags on the walls. There was artwork done by local Aboriginal artists. There was acknowledgements of country at the entrances to the buildings. And all of this stuff can sort of seem a bit tokenistic if it's just done independently, but combined with everything else that was going on, it was, yeah, just like another expression of their support and respect. They actually had special uniforms that staff could wear, not just the Aboriginal staff, but all staff, with Aboriginal artwork on them to sort of show their support. They had cultural events and a mandatory cultural awareness training for all staff as well, which was tracked in KPIs. And an interesting thing was just the culture of respect in these two organisations, and this came through very strongly in every interview. I was fortunate enough to read all the interviews, and I've included a few quotes on the slide from some of the staff that we spoke to, both Aboriginal and non-Aboriginal, about that culture that just sort of was in every single interview. And there was some really great positive outcomes that came out of this. Both the patients and the staff were reported that having the Indigenous staff members, particularly the Indigenous liaison officers, involved in their care really improved outcomes for the Indigenous patients. The Indigenous patients reported that they felt better supported, and they were more likely to stay in hospital and continue with their treatment through that support they were receiving. And the Indigenous staff were really positive about working for these organisations. They reported feeling respected and listened to and part of the team. And both services were doing really well with recruitment and retention. They both had a number of long-term Indigenous employees, no unfilled vacancies. And the urban service also had a really strong cadetship program as well, where they were supporting Indigenous health students. They did support, I think, over 20 Indigenous health students over the last decade through to the completion of their degree and into careers in health. So a lot of different things that they were doing, which is fantastic to see, and unfortunately isn't the case at a lot of other health services here in Australia. We also spoke to Aboriginal cancer patients and their families. This was a really important part of our research. It wasn't just for the services to say that they thought they were doing well in this space. We wanted to hear from the patients and their families to see what they thought of the services. And I'm pleased to report that that's one of the reasons why these services, or the main reason these services have been identified as high performing, is that the Aboriginal cancer patients and their families just had such, good things to report, and were very positive about these services and the care that they had received. Some things that the patients and their family members specifically highlighted that they felt had really helped them. The staff really spent extra time with them to build that rapport, really taking the time. The patients felt involved in the decision-making process, And as mentioned previously, they really valued having the Indigenous staff involved in their care. They also really valued having their family included and supported. In Aboriginal culture, family doesn't always just mean nuclear family of parents and children. It can mean quite an extended family network of aunties and uncles and cousins, and these people are really important. And unfortunately, that isn't always very well acknowledged in Australian culture, and particularly in hospitals. That's not very well understood or supported. But these two services did understand that and really made the effort to include extended family and make sure that everyone who needed to be at the table for family meetings was. And they also used telehealth as a way of improving communication between patients and family members, particularly where family were located in regional or remote areas. Telehealth, obviously, post-COVID, that's not so innovative, but back in 2018, when we were doing the case study, unfortunately, telehealth wasn't very commonly used in Australian healthcare, particularly not in the way that these services were using it. They were using it to orientate patients. So they were reaching out to the patients before they were admitted to the cancer service to just sort of orientate them to the service, let them know where they'd be coming, what they might need to bring, just to try and remove some of that fear of coming to a big city and coming to a big Western hospital. And they were using the telehealth to connect patients once they're in the service back with their family for, like I said, for family meetings and things. And then obviously for once they were discharged as well, to continue keeping in contact with the patients after discharge so that they didn't have to travel back to the service. However, despite all those wonderful positive things that the patients reported, they also reported that they found the journey to the cancer service to be really challenging. They said that the time between when they first experienced symptoms and getting to the cancer service was confusing, it was stressful, and there were lots of reasons for this. A lot of issues navigating the health system, medical delays, poor continuity of care from primary health providers, misdiagnosis even, and certainly poor communication. The services that we spoke to were aware of these issues, that were trying to mitigate them, but with mixed success. And I think that's definitely an area where more work needs to be done. And I know certainly we're very aware of how great it would be to have Aboriginal cancer navigators here in Australia. There's been a few attempts to get something like that off the ground, and I think that's something that we can definitely learn from what you're doing over in Roswell. So out of our research, we've made some recommendations to health services here in Australia, just to help them to sort of improve the cultural safety of their care. And a big one, like I've already flagged, is developing a vision statement and just embedding it in the policies and the processes. And having things like an Indigenous employment strategy. A lot of organisations here, particularly hospitals, don't have that yet. Another one, and it probably seems kind of obvious, but finding out who your Indigenous staff are. Unfortunately, a lot of services that I spoke to, particularly the metropolitan services, weren't actually sure who their Aboriginal staff were. They weren't sure if there were any Aboriginal staff working for the organisation. That's terrible. I mean, you can't support people if you don't know who they are. So being able to know who they are so you can support them. And similarly, being able to identify your Indigenous patients as well. That's been a big push here in Australia to make sure we've got processes in place to accurately identify and record patients who choose to identify as Aboriginal or Torres Strait Islander. But unfortunately, across the health services that we spoke to, there was still quite a bit of variation, and a lot of services still weren't asking the question of every single patient as to whether or not they identified as Aboriginal or Torres Strait Islander. And of course, people can choose not to identify, but it's important to at least ask the question and give the patient the opportunity to identify. Unfortunately, some services here are still sometimes making assumptions based on people's appearance and things, which is obviously terrible. So that's a big recommendation from our study. Increasing engagement between the health service and their Indigenous staff, their patients, and also the local communities, and getting their input into the system and the health service. Creating a welcoming environment. I've already touched on that, having flags, having artwork, just to make the environments sort of more welcoming. Looking at the recruitment processes of the health service and just making sure that you remove any barriers for Indigenous job seekers. That was something that both the services that we'd done had sort of really focused on. Looking at your orientation to your organisation for new staff and just making sure that all new staff are aware of the importance of Indigenous health to the organisation and just really setting those expectations up front. And creating a supportive environment for the Indigenous staff through initiatives such as an Indigenous employee network or improving, providing access to culturally safe mentoring. So lots of different recommendations that we had. I won't list out all of them, but those were some that we've sort of really been sort of trying to communicate here in Australia to health services to improve. And then we also had some cancer specific recommendations as well, although these wouldn't necessarily have to be specific to just cancer, they would apply to other hospital wards as well. But making sure that the Indigenous liaison officers, in particular, and the Indigenous staff are notified of new Indigenous cancer patients. Like I said, the services we spoke to had actual inputted IT systems in place to support that. Making sure that the Indigenous staff are included in multidisciplinary meetings and provided with opportunities to attend professional developments, including backfill. That was a big issue here in Australia, particularly for regional and remote health services. They're so short-staffed that particularly the Indigenous staff, they just weren't provided with backfill if they wanted to go and attend training, which meant that they just couldn't attend training because then no one was in the role. And then burnout becomes a huge issue there as well. So really sort of respecting those roles by resourcing them adequately. Telehealth was a finding. Obviously that's come a long way in recent years through COVID, but using telehealth in various innovative ways, including to improve communication with patients. I think those were probably sort of some of the main recommendations I just wanted to highlight from my research. So that sort of brings me to the end of the formal talk. I want to give lots of time for discussion and questions, but I think I just want to highlight that for us, this research was fantastic because it showed that Aboriginal patients and staff can feel supported and respected in a large mainstream health service here in Australia, which unfortunately hasn't been the case in the past. So thank you.
Great, thank you for the presentation. So please put the questions and comments to the chat or Q&A so we can go through some of the questions to this about the great work they are doing and the specific aspect of care and initiative recommendation. So I guess while we are waiting for the question to come through, I can start with some of the question. I think we talked about how a lot of the similarity between all across the world, but Indigenous people going through. I'm just wondering, is there something unique in the Australian Indigenous people? Maybe it's because of the healthcare system in Australia is different from, let's say, United States, or maybe culture. Is there anything unique among them to experience in going through the cancer care? And is there any specific solution you found that provide the care for them? Maybe you'll discuss question.
Sandy and Leanne, is that something that you would like to answer?
I'll say one thing. I think, Sandy here, it's probably, I I think what we were trying to do with the study that Emma's described is kind of look for sort of strengths in cancer service delivery. And I would hate everyone to go away and think that it's terrible everywhere else, because I don't think that would be right. Okay. And I think cancer services have come a very long way, but we were going in through the lens of cancer service delivery. And what we found is you don't get good cancer service delivery unless the whole health service is kind of, and specifically for Aboriginal people, unless the whole health service is actually kind of focused on providing good care and support for Aboriginal people. And you don't just support the patients, you have to support your workers as well. So I think that was one thing. I do remember right at the very beginning of this research, it was quite a long time ago, when I had rung up an oncologist. I'd said, oh, we're doing this research and we wanted to find out why, things, why is there these disparities in cancer outcomes for Aboriginal people? And he basically said to me, oh, I can tell you why that is. It's basically a sausage factory here, and if you don't fit the sausage, in other words, he was basically saying it's protocol driven. It's very rigid the way that we deliver the services, and so if you don't fit into that, we can't accommodate it. And I mean, I was pretty horrified at the time, but in a way, I think what he was kind of reflecting the way cancer services at that time were delivered, that they weren't very accommodating of cultural difference at all. And I do think that Emma mentioned closing the gap, and we've been on a journey in Australia about learning about the history and the many wrongs that were done to Aboriginal people in the past, that they're still very much in the forefront of people's minds in terms of whether they trust the services that they're going to. So I think I would sort of give that little bit of context about it takes a long while to build that trust again. And so the importance of those Aboriginal staff that Emma was referring to is that is part of building the trust, because there's a more natural connection, there's a greater understanding. If I'm a non-Aboriginal, doctor, I see what I see, but the tip of the iceberg, but I don't know everything that's going on in that person's life below that. Whereas other people who have a bit of shared experience probably are much more attuned to some of those challenges. And I don't think that means that we are insensitive or we don't understand some of those things. But I think the other big value, and I mean, I say this having worked with both Leanne and Lenny over quite a few years, is that we learn so much from our Aboriginal colleagues that we don't learn just from going to training, in how to deliver a health service, for example. Leanne.
Yes, I agree with that, Sandy. I think a lot of clinicians just see the clinical problems, issues, and there's a lot more things that they need for social support with Aboriginal people. Sometimes it's just as simple as not knowing the distance in isolation. We still have clinicians that think that, okay, we've got a space come up in an appointment for tomorrow, can you make it down? Not realising that the patient has to come 2,400 kilometres. And even if they are near a major centre like Geraldton or Port Hedland or Karratha, there still isn't any treatment options there. The majority of patients, Aboriginal patients and regional patients in WA, have to come down to our major city for treatment, and sometimes even for a good diagnosis. And I think it's also, they've got to be more, it's got to be more than just a visual welcome. It's no good having a welcome to country or an acknowledgement of country and all the Aboriginal art and words in the world if you have a receptionist who is going to ignore an Aboriginal patient. So, you know, it has to be a lot more than that, just that as well. I think the services that were performing well, they had a lot of ducks in a row. But if one of those things fall down, as Emma mentioned, if one of those things fall down, the whole service can be affected negatively. So I don't know that there's anything in particular that Aboriginal people are doing, or you know, in the services. I think we are becoming more, as an Aboriginal woman who has been through cancer treatments with multiple family members, it has improved since the early 2000s when I first had an experience with cancer with my family. You know, they're letting spaces for families now. While we don't have the cancer navigators, there's the ALOs who, a little way though that they are burnout. They're everything to everybody within the hospital system. And what Emma said about the identifying as Aboriginal can also be an issue. We've had people say, I don't know how to ask a person if they're Aboriginal. You know, non-Indigenous receptionists can say, I know I should ask this question, but I don't want to cause offence. What's offensive about being asked if you're Aboriginal? It shouldn't be thought of as an offensive. So there's a long way to go. There's really a long way to go. It's not all bad. And I believe that the majority of our clinicians want to provide the best treatment they can. They just needed to be nudged in the right direction. In a cultural way, not just in a clinical way.
I see. Yeah, trust and cultural sensitivity is really important. I see. So there's some question coming in. One from Bridget. Do other hospitals, institutions acknowledge that they need to improve their processes to make Indigenous staff and patients feel welcome? So you guys talked about Hughes, Hughes Hospital, but any other hospitals, how that they feel like Indigenous people?
I might start with this one, and then I'm not sure if any of my colleagues want to add as well. But yes, they do, definitely. And as Sandy said, I mean, we've just highlighted the two which were doing really well, but there are lots of other services that are doing well in this space or are doing not quite as well, but also making really good efforts. So I shouldn't, maybe I was a little bit too negative there in my talk. But as part of our research, before we did the case studies, we went and we tried to survey all the cancer services in Australia, and then we did those telephone interviews with 14 services. And yes, I think certainly not all services, but certainly the majority, there was this vibe that they wanted to do more in this space. They wanted to do better. They just weren't sure how, and they weren't sure who was doing well in this space that they could go and learn from either. That was quite a clear finding from our research, that they just weren't really aware of who was doing well. So that was part of the justification, I guess, for our research then, when we were able to identify these services, is then to try and share it back with all the other services to try and let them know. And that has not a lot, but there have been a little bit of services contacting me and saying, oh, hey, can you put me in contact with that service that's doing really well? We want to learn from them. So I think they are trying to do better, but, you know, they're all at different stages on their journey.
I see.
Anyone else want to add anything on that point?
No.
No.
You've done well, Emma.
Okay, then there are questions and comments from Shannon. Great presentation. I think it's amazing that you have Indigenous liaison, and there is action made toward reconciliation. Hopefully the healthcare system can be used as a model for other centers. Is there work being done to incorporate Aboriginal traditional medicinal people into cancer care continuum?
Lenny and Leanne, would you guys?
Yeah, I'll answer that. People that I've interviewed take their own traditional medicine with them when they go to have their treatments. And when they talk to the doctors, they tell them that they also have their bush medicine. That's their cultural belief, and that they'll take that as well as the other treatment.
Yeah, also, traditional healers are also incorporated. If the families want to use them and they have somebody in mind specifically, that we can also enable that.
I see. So how they doctors and clinicians see Indigenous people coming and wanting to have a traditional medicine in the clinical setting, how clinicians see those things? I'm not sure how to answer this question.
Yeah. When people go to hospitals, they always have family members go with them. You'll find there's a family member that will step up and talk to the clinicians or the doctors and say, hey, we've got some traditional bush medicine. We want him to use this. So they will be the spokesperson for the person that's not well. Or if the person is well, they'd be quite happy to speak up for themselves.
I see.
It's about
I
that
think it would be-
communication.
I think it would be fair to say that around Australia, there would be huge variation in how traditional Aboriginal medicine is received within hospital settings, despite the fact that we've changed a lot over time. Yeah, I suspect that in the Northern Territory, for example, they would be more receptive to traditional bush medicine and to traditional healers, because people are have been living a more traditional lifestyle. And I think it's also important to say that there are many Aboriginal people who don't particularly want to use bush medicine as well. So we've got a huge variation across Australia. But I think on the whole, health services, as part of trying to be sort of more culturally safe, are much more open to traditional healers and to bush medicines doctors generally say, look, we'd much prefer you to tell us what you're taking than to not tell us. So generally it's been encouraged that there is that conversation if people do want to take bush medicine.
There seems like some comments coming in and saying, great work you guys are doing, and learned great presentation. We learned so much. Let's see. I think time is coming up, so I just want to have one last question. Is there any suggestion for us who's working in the United States or with the Indigenous people? Is there any suggestion for how to improve our cancer care in the Indigenous people in the United States? Very general question.
I think we have very, very different health systems in many ways, don't we?
Yes,
and
definitely.
It's very hard to sort of comment on that, I think, in the absence of, understanding how healthcare is paid for. Australia is lucky in that we do have universal health insurance. So everybody should be able to access, cancer services. It doesn't mean it all works perfectly, of course, and it doesn't mean that there's only one tier of service delivery. But I think on the whole, we're not bad. Whereas I think in the US, the costs of accessing healthcare is sort of unaffordable for some people. And I presume that that goes for cancer care as well. And that must have huge impacts upon people's ability for timely access to healthcare. So I think that is one way. You know, you have to look at the healthcare financing system and whether it actually allows and encourages people to access care. That's kind of the system within which care is provided, as well as, you know, all of those other aspects at the patient level about cultural security and so on. So, I mean, that would be my big takeaway on all of that.
Yeah, definitely. Health insurance is a big thing. Yeah, big issue here. So is there any other comments or anything?
Can I just say that it's Leanne here, that it is great to be involved in something like this. That's an international project, I guess. And I noticed in the chat, somebody said that a lot of the things that we've gone through as Indigenous people in Australia, the Native Americans have gone through. I've noticed that somebody mentioned that as well, and that we've had a lot of the same health outcomes, social and economic outcomes as a result of the dispossession and oppression that we've suffered as peoples. And it's great to be working together to sort of share this information.
Yes, and what I'll say as a representative of the Center for Indigenous Cancer Research is I honestly feel like we're listening to our own story. And I know that one of our community leaders and well-respected leaders, and Pete Hill made a comment that I think that you were alluding to. The commonalities are striking. The challenges are strikingly similar as well. And I do believe that even for us as a Center of Indigenous Cancer Research, we certainly could use the work of some of the hospitals across the pond as a model for potentially how we improve cancer treatment services in our part of the country, our hospital specifically. So this has been great, and I want to thank all of our panelists for their contributions, all their work, their respective work, their time. The time difference is considerable, so I believe it is close to 11 p.m. in Western Australia. So we are very grateful for them accommodating us and providing, like I said, comparing and contrasting their work. It's been very inspirational for us. And also special thanks to Dr. Bataille for being a liaison of sorts between us and our colleagues in Australia and introducing us to their work. And I'm hoping that there's potential for future collaboration and future discussions, because I think it's sometimes we think that we're isolated and our problems are isolated to our local communities, but as we're seeing this as international, these same challenges and potential solutions we might be able to find in not just our own communities, but abroad. So been a wonderful discussion, and I want to thank everybody who attended the session today. We'll be holding 3 more webinar sessions throughout the year, so be on the lookout for those ones, and we hope to see you soon. Yahweh, thank you.
Thank you.
Thank you
Bye,
very much
everyone.
for this opportunity.
Thank you, everyone.